What if the very checkup meant to protect you is the thing that puts you in a hospital bed instead? Right now, somewhere in this country, a healthy 68-year-old is sitting in a waiting room, feeling perfectly fine, about to agree to a test that could change everything for the worse. Before I tell you which 5 checkups I would personally avoid after 65, let's make a quick deal. Tap that like button right now. It costs you nothing, but it tells me you want more videos like this one, honest, research-backed, no sugarcoating. And if you haven't subscribed yet, do it before you keep watching, because the next video might be the one that saves someone in your family from a mistake they never saw coming. Deal made? Good. Let's get into it. I'm a physician, and for years I've spent my free time doing something most doctors don't have time for. I read the actual studies. Not the headlines, not the pamphlets in the waiting room, the raw data. I sit with the numbers until they actually make sense in plain language, because that's the only way any of this becomes useful to a real person instead of just sounding impressive on a slide. And what I found changed the way I think about medicine for people over 65. There is a quiet truth buried in the research that almost nobody says out loud during a rushed 15-minute appointment. Some of the most common tests we offer to older adults do not help them. In certain cases, they actively hurt them. Not because doctors are careless, not because medicine is a scam, but because something fundamental shifts as we age, and very few people are accounting for it. I call it the tipping point. At 45, screening is almost always worth it. Find a problem early, treat it, and you might buy yourself 30 extra years of life. The math is simple and the odds are heavily in your favor. But somewhere around 65, and even more so after 70, that math starts to bend. 3 things happen at once, and together they quietly flip the equation. First, many of the problems screening finds in older adults were never going to hurt them in the first place. They grow so slowly that you would die of old age long before they ever caused a symptom. But once a scan picks something up, the system rarely says, let's just keep an eye on it. The system says, let's treat it. Second, your body's ability to bounce back from an intervention changes. A procedure that a 50-year-old shrugs off in 10 days can mean weeks of hospital stays, complications, and lost independence for someone in their late 70s. The same surgery, 2 completely different outcomes depending only on the calendar. Third, there's something I call the domino effect. One borderline result on a routine test leads to a follow-up scan. That scan leads to a biopsy. The biopsy leads to a procedure. The procedure causes a complication nobody saw coming. And just like that, a person who walked in feeling completely healthy is now living inside a medical emergency that started with a test they didn't actually need. None of this means screening is bad. It means screening is a tool, and like every tool, it has to be used at the right time, on the right person, for the right reason. A hammer is wonderful when you need to drive a nail. It's far less helpful, sometimes even harmful, when what you actually need is a screwdriver. Medicine often hands everyone the same hammer no matter their age, and that mismatch is where things start to go wrong. Keep this idea in your head as we go through each one because it explains everything we're about to cover. This isn't a fringe idea either. Researchers who study overtreatment in older adults have found that a meaningful share of procedures performed on people past 70 offer little to no measurable benefit in survival or quality of life, while still carrying the full weight of surgical and procedural risk. That gap between effort and benefit is exactly what we're going to walk through, one checkup at a time, starting with the one that catches more families off guard than almost any other. Let's start with the first one, and it might be the most common mistake happening in doctors' offices right now. Routine colonoscopies after age 70 for people who don't need them. Let me tell you about Margaret. She was 71, a retired school teacher from Ohio, the kind of woman who walked 2 miles every morning and hadn't missed a Sunday dinner with her grandkids in years. She'd already had 2 colonoscopies in her life, one in her 50s and one in her 60s. Both came back completely clean. No polyps, no family history of colon cancer, no symptoms of any kind. But her new doctor glanced at her chart, saw it had been a while, and told her she was due. Margaret didn't want to seem difficult, so she agreed. The night before the procedure, she drank the required prep solution to clear out her system. By morning, she was disoriented, weak, and barely able to stand. Her son rushed her to the emergency room before she ever made it to the appointment. Her electrolytes had dropped to a dangerous level. Her heart rhythm was unstable. She spent 4 days in the hospital recovering from a colonoscopy she never even had. And here's the part that should make you angry. She never needed it in the first place. The leading medical guidelines in this country actually recommend against routine colonoscopy screening for average-risk adults over 75 who have clean previous results and no symptoms. The evidence behind this is solid. Past a certain age, the risks of the procedure itself start to outweigh the benefit of finding something. And those risks are not small. A tear in the colon wall happens in roughly 1 out of every 500 colonoscopies. In a younger, healthier body, that's a serious but survivable complication. In a frail 78-year-old, it can mean emergency surgery, a colostomy, and months of recovery that permanently changes how someone lives. Meanwhile, the slow-growing cancers most likely to be caught in an asymptomatic older adult often grow so gradually that they would never have caused a single problem in that person's remaining years. There's a phrase researchers use for this. They call it dying with it, not from it. It sounds harsh, but it's honest, and it's exactly why age matters so much in this decision. A polyp that takes 15 years to turn dangerous is a real threat to a 50-year-old. It's often irrelevant to someone in their late 70s, simply because of how time works. So what should you do instead? Ask your doctor about a simple stool-based test you can do at home, like a fecal immunochemical test. It catches genuine warning signs without putting your body through an invasive procedure. And if you do have real symptoms, blood in your stool, sudden changes in your bowel habits, unexplained weight loss, that changes everything. Get evaluated immediately. This isn't about avoiding care, it's about avoiding care you don't actually need. The second checkup deserves a careful explanation, because I am not telling you to skip cancer screening altogether. Cancer screening has saved an enormous number of lives, and it might save yours too. What I'm talking about is aggressive, repeated PSA testing in men and yearly mammograms in women who are over 70, low risk, and showing no symptoms at all. Here's the problem in plain terms. Our imaging technology has become so sensitive that it now finds cancers that are, biologically speaking, almost asleep. Tiny, slow-moving tumors that would never spread and never shorten a person's life if left completely alone. You would die with these, never from them. But the second a report uses the word cancer, the entire medical machine switches on. Biopsies, specialist visits, treatment plans, all of it moves forward, often without anyone stopping to ask whether this particular cancer was ever going to be dangerous. Take Walter, a 78-year-old retired contractor from Georgia, strong, sharp-minded, still doing light work around his property every weekend. A routine PSA test came back slightly elevated. The biopsy confirmed a low-grade, slow-growing prostate cancer. His doctor recommended radiation therapy, and Walter trusted that advice completely. Within a year, he was dealing with chronic fatigue and urinary problems that never fully went away. His quality of life dropped sharply. Looking back, he often said he wished someone had told him this was the kind of cancer he likely would have lived alongside for the rest of his life, without ever knowing it was there. Research published in major medical journals has found that a significant share of cancers detected through mammograms in women over 70 were what doctors call clinically insignificant. That means the treatment that followed offered no real survival benefit, only the side effects. This is the part that's so hard for people to wrap their heads around. We've been taught our whole lives that finding cancer early is always good news. And for most of our lives, that's true. But biology doesn't follow a single rule for every age. The same word on a report can mean something completely different depending on how many years a person has left to grow it, and what kind of cancer cell is actually involved. So here's what to do instead. Have a direct, honest conversation with your doctor about your real risk level. If you have a strong family history or genetic risk factors, screening still makes sense, and you should absolutely continue. But if you're low risk with no symptoms, ask one simple but powerful question. If we find something, what would treatment actually look like at my age, and would it genuinely extend or improve my life? That single question changes the entire conversation because it forces everyone in the room to think past the diagnosis and into what actually happens next. If this is making you think differently about your next checkup, type the word "aware" in the comments below. I read every comment, and it helps me understand how many of you are actually rethinking these decisions with me. Now let's talk about the third checkup, and this one surprises people because on the surface it sounds completely reasonable. Routine cardiac stress testing for someone with absolutely no symptoms. Your doctor says you're 70, let's just make sure your heart is okay, and puts you on a treadmill or gives you a medication that mimics exercise stress while monitoring your heart. It feels responsible. It feels caring. But here's what almost nobody tells you. In people without symptoms, cardiac stress tests have a false positive rate that can climb above 40% in certain age groups. That means nearly half the time, the test flags something abnormal, even though the heart is actually fine. But medicine rarely just shrugs off an abnormal result. That false alarm pushes you straight into a cardiac catheterization, a procedure where a thin tube is threaded through a blood vessel in your wrist or groin directly into your heart. It carries real risks, including bleeding, vessel damage, irregular heartbeat, and in rare but documented cases, it can actually trigger the very heart attack or stroke it was meant to prevent. Here's where it gets even stranger. If the catheterization finds a partial blockage, which is extremely common in people over 70, even those with zero symptoms, you may walk away with a cardiac stent. But major clinical trials, including a well-known study called ischemia, found that placing stents in patients with stable coronary artery disease did not reduce heart attacks or extend life compared to medication and lifestyle changes alone. Read that again. The stent didn't outperform the pills, but it came with its own risks plus a lifetime of blood thinners and their own bleeding complications. So picture the full chain. You felt completely fine. A routine test gave a false alarm. That led to a catheterization. The catheterization led to a stent. The stent led to blood thinners and lifelong monitoring. And at the end of it all, you are statistically no better off than someone who simply controlled their risk factors with medication and a daily 30-minute walk. That's not a guess. That's what the data from multiple large trials actually shows, and it surprises even some doctors when they see it laid out clearly for the first time. What should you actually do? If you have no chest pain, no unexplained shortness of breath, and no dizziness during normal activity, focus your energy on the things that genuinely move the needle: blood pressure, cholesterol, blood sugar, daily movement, sleep quality. That's where the real protection comes from, not a treadmill test searching for trouble in a body that isn't showing any. Notice the pattern forming here. In every example so far, the safest path wasn't the one with more machines or more procedures. It was the one built around steady, boring, unglamorous habits. That pattern holds for the next checkup too, and it might be the clearest example of all. The fourth checkup tends to make people uncomfortable when I bring it up because bone health is real and falls in older adults are genuinely dangerous. So let me be precise. I'm not questioning whether bone loss matters. I'm questioning what automatically happens after a bone density scan in people over 70. A DEXA scan detects low bone density, and the very next step is often a prescription for a bisphosphonate medication, something you're told to take for years, assuming it's quietly protecting you. Here's what often goes unmentioned. Long-term use of these medications has been linked to a rare but serious condition called an atypical femoral fracture, a spontaneous stress fracture in the thigh bone, the exact bone the medication was supposed to protect. These fractures are severe and usually require surgery. These same drugs are also linked to a painful jaw condition that is notoriously difficult to treat. None of this is meant to scare you away from a medication that genuinely helps many people. It's meant to make sure you're choosing it with full information, rather than simply because a number on a scan crossed a line on a chart. Meanwhile, the single most effective way to prevent fractures in older adults isn't a pill at all. It's preventing falls in the first place. Balance training makes a measurable difference. Practices like Tai Chi have been shown to cut fall risk by nearly half. Removing tripping hazards at home, installing grab bars, getting your vision checked regularly, reviewing medications that might cause dizziness, and getting enough protein and vitamin D in your diet all reduce fracture risk more meaningfully than a pill and with zero side effects. Think about what that actually means. The intervention with the best results and the lowest risk isn't sitting in a pharmacy. It's sitting in your daily routine. And almost nobody gets told that during a rushed appointment. I'm not saying medication is never appropriate. For people who've already broken a bone or have very low bone density readings, it absolutely can be the right call, and it has genuinely helped a lot of people avoid a second fracture. But for an active 74-year-old who has never broken a bone in their life, jumping straight to long-term medication deserves a real conversation, not an automatic prescription. Ask your doctor this before agreeing to anything. Can we review my actual fall risk first? And how does this medication's benefit compare to a structured fall prevention plan? Quick pause here. If you've made it this far, take a second and share this video with one person in your life over 65. Not because I'm asking for a favor, but because the next checkup might be the most important one in this entire video, and somebody you care about needs to hear it before their next appointment, not after. A 2-second share could end up being the most useful thing you do for them all month. The fifth checkup is one almost nobody talks about, and based on everything the research shows, it might be the most quietly dangerous of them all. Routine carotid artery ultrasound screening in people with absolutely no symptoms. This test checks the large blood vessels in your neck that carry blood to your brain. The logic sounds airtight. If we find a blockage, we clean it out surgically and we lower your stroke risk. Simple, right? The reality is far more complicated, and for people without symptoms, far riskier than it sounds. This is the checkup that surprises even people who followed me through the first four, because it looks like prevention and behaves like prevention, right up until the moment it doesn't. Here's the critical fact. The surgery used to clear a blocked carotid artery carries a 2 to 3% risk of causing a stroke during or immediately after the procedure itself. In older adults, especially those with other health conditions, that risk climbs even higher. Leading screening guidelines explicitly recommend against routine carotid ultrasound testing in people who have no symptoms whatsoever. No mini strokes, no sudden vision problems, no weakness, no warning signs of any kind. The research is clear that in these cases, the danger of the surgery outweighs the benefit of finding the blockage. Here's why this matters so much. A large number of people over 65 have some narrowing in their carotid arteries that has quietly been there for years, completely stable and never causing a single problem. When you go looking for it with a routine scan, you find it, and once it's found, a well-meaning surgeon often recommends fixing it. But the surgery itself, the one meant to prevent a stroke, can dislodge a small piece of plaque that travels straight to the brain and causes the very stroke everyone was trying to avoid. There are documented cases of people walking into a routine screening appointment feeling completely normal and walking out on a path they never expected, not because of the blockage that was sitting there quietly for years, but because of what was done about it. It's one of the clearest examples in all of medicine of a treatment causing the exact harm it was designed to prevent. So what should you actually focus on instead? If you have no symptoms of stroke, no sudden vision changes, no facial drooping, no arm weakness, no sudden severe headache, then routine carotid screening generally isn't recommended for you. Put your energy into the things that actually reduce stroke risk. Managing blood pressure, since it's the single biggest driver of stroke. Controlling blood sugar, quitting smoking if you smoke, managing irregular heart rhythms, staying physically active, and if you ever do experience any neurological symptom, even one that goes away on its own, get evaluated right away. That changes everything about the urgency. Now, I promised you something practical, so here it is. The next time any doctor recommends a screening test, especially if you're over 65 and feeling well, I want you to have 5 questions ready in your back pocket. Write them down, save them in your phone, bring them to every single appointment from now on. Question 1. What is the false positive rate for this test in someone my age? This tells you how likely the test is to send you down a path of unnecessary follow-up procedures even when nothing is actually wrong. A test that sounds simple on paper can open a door you never wanted to walk through, and knowing the odds beforehand changes how you weigh that decision. Question 2. If this test finds something, what would realistic treatment actually look like for someone my age and health? This shifts the conversation from just finding problems to understanding outcomes. It's easy to agree to a test without ever picturing what happens 6 months later if the result comes back abnormal. This question forces that picture into focus before you ever sit down for the test itself. Question 3. What is the actual risk of any procedure we'd likely pursue afterward? This is the question almost nobody thinks to ask, and you deserve a clear answer before you agree to anything. Every single procedure in medicine carries some level of risk, even the ones that sound routine, and you have every right to hear that number out loud. Question 4. What happens if we simply monitor this instead of treating it right away? For many conditions found in older adults, watching closely over time is a completely legitimate and often smarter choice than jumping straight into treatment. Watchful waiting isn't doing nothing. It's a deliberate, evidence-based strategy. And in many cases, it's the option with the best outcomes attached to it. Question 5. What is the most effective non-invasive option for this condition? Time and time again, whether it's bone health, heart health, or stroke prevention, lifestyle changes and simple medications outperform invasive procedures with a fraction of the risk. This question alone has changed the entire treatment plan for patients I've spoken with, simply because nobody had asked it out loud before. Any good doctor will welcome these questions. They will respect you more for asking them, not less. And if a doctor brushes off these questions or makes you feel like a burden for raising them, that tells you something important about whether that doctor is truly the right fit for the rest of your life. I want to leave you with this thought. There is a real difference between medicine that finds things and medicine that helps you actually live well. After 65, the goal of your healthcare shouldn't be to generate more findings on a chart. It should be to protect your independence, your energy, and your ability to keep doing the things that matter most to you. The wisest doctors I've ever known understand something that's easy to forget. Sometimes doing less takes more courage and more skill than doing more. Recommending patience and careful watching often takes more confidence than simply ordering another scan, because it means standing behind a decision that won't show up as a number on a report. Think back to Margaret, to Walter, and to every patient whose name never makes it into a video like this one. None of them were careless. None of them ignored their health. They trusted a system that doesn't always pause to ask whether a test makes sense for the specific person sitting in the chair. That trust is exactly what I want you to hold on to, while also learning to ask better questions before you spend it. You have every right to ask what a test is actually looking for. You have the right to know what happens next if something is found. You have the right to ask whether a finding would even be treated, and whether that treatment would genuinely make your life better or simply give you a new problem to manage. Modern medicine has given us extraordinary tools, but a tool only helps when it's used at the right time, for the right person, in the right context. You are that person. Your years ahead deserve a healthcare experience built around your goals in your life, not around a checklist someone else created without ever really knowing you. If this video changed the way you'll walk into your next doctor's appointment, that's exactly why I make these. Hit subscribe, not because I'm asking for a number to go up, but because there's a real chance the next video could change a decision for you or someone you love, and that matters more to me than anything else. I'd rather have a smaller audience of people who actually use this information than a big one that scrolls past it. So if that sounds like you, stick around. And before you go, tell me in the comments, has a routine test ever taken you somewhere you never expected? Your story might be the exact thing someone else needs to read before their own appointment next week. Take care of yourself, and I'll see you in the next one.